My name is Justin Nutt. I'm the CEO and founder of Nurstead Mental Health and Consulting Services, and I'm here today to discuss what mobile crisis teams are and how they can help you as a first responder. I thought most first responders have heard of mobile crisis teams, on-scene mental health responses, but not had them available to respond to calls they've encountered. With law enforcement, fire, EMS, on a daily basis, you most likely encounter individuals and calls that are connected less to your primary roles protecting the public and providing medical services, and are more crisis and mental health related instead. Some of these calls may come in as medical calls, where an individual might report that they believe they're having a heart attack. And when you get there as EMS, what you find is the individual is experiencing symptoms of anxiety, having a panic attack. For law enforcement, a suspicious individual call might come in, or you might see someone on the street who's acting erratic. They may be psychotic, present no other danger to themselves or others. This is where mobile crisis teams can really be of assistance. In the past, when one of these individuals was encountered, especially an individual where there are mental health concerns, that individual was directly transported to the emergency department of the closest hospital. Or, in some cases, that person was taken to jail due to repeated calls or a lack of other options. And neither of these options address the true need here. For most areas, law enforcement, fire, and EMS are already stretched amazingly thin, and simply leaving the scene isn't an option. Also, having a long discussion can prevent that first responder from attending to the next call. These are times mobile crisis teams are specifically designed for. So what is a mobile crisis team, or an MCT? Well, an MCT is a behavioral health-led team made up of therapists, certified peer supports, and other mental health professionals. When an individual is suicidal, depressed, anxious, experiencing psychosis, or in some other form of crisis, that's when we're contacted. Mobile crisis can be easily activated in one of two ways. The first is you, as a first responder, calling dispatch over the radio and having them contact our on-call clinician. The other is for you directly to call our crisis line, which is staffed on 24 hours a day, 365 days a year by the responding clinician, and request that response yourself. So what does a response look like? Well, once a mobile crisis team arrives on scene, we'll meet with the requesting first responders to get briefed on what the specific needs of the individual are, see if there are any medical or safety concerns, and at that point, the first responders are able to turn over the scene to us as long as the individual who is in need of behavioral health services is both medically cleared and the scene is considered safe. This allows the first responders to go back on duty and be available for that next call. Now, our whole goal is to avoid that trip we talked about to the ER for two major reasons. Just as police, fire, and EMS are spread thin in most areas, hospital emergency departments are as well. Also, mobile crisis teams are designed to find solutions. Individuals taken to the ER or a hospital, that assessment is completed, is designed to answer just one simple question. Do they need to be inpatient at a psychiatric hospital, or are they going to be released? And resolution, resources, isn't the outcome for those individuals who are released. On the flip side, mobile crisis team members are there to find a way to address and resolve the current crisis, and we take as long as needed to do exactly that. The reality is that most individuals, they don't need to be replaced. Most individuals need help in a crisis situation. They need somebody to talk to. They need to have, brief clinical interventions, crisis therapy, if you will, resource provision, help with coping skills, supporting family members, and to de-escalate the crisis. And then they need follow-up to that once that plan is in place and created. Now, response time for the state of New Mexico set at 90 minutes is ideal. For our mobile crisis teams, we don't think that that's good enough. In most cases, we attempt to respond within 20 to 30 minutes. Some individuals on scene might think that this seems like a long wait, and request is be taken to the Nurstead. What we found is if you as a first responder are able to explain to them that, they're looking at 4 to 6 hours of being in that ER before they're able to either be released or know if they're going to be released. The hospitals are going to run their standard tests to ensure the person is medically cleared. And if placement is needed, that way they can transfer that individual hospital to hospital. It's going to be a several-hour process. After that, then somebody would be called in to discuss with that person about what's going on and assess whether they need to be placed or released. Rarely are resources provided, rarely is follow-up provided. So what about other cases? What I can say is out of over 400 calls that have happened in the past 2 years, Nurstead has only placed approximately 15 people in acute placement situations. So to have them transported to an ER and then to a psychiatric facility. All those other individuals who traditionally would be transported to the ER, you're looking at a 4 to 6 hour wait where little resolution is going to be. But there are those other cases. So while we have a de-escalation rate that's that high and that few people get placed, there are those 15 individuals. In those situations, we will have done an assessment on scene, determined that they do need to be placed at a psychiatric facility, and then we'll request transport from that scene to an ER. And we can make that a little bit easier in those situations in most cases because we will have already discussed what's inpatient placement look like. Answer any questions they have or their family have. Talk to them about the appropriateness and the need for it and de-escalated that confrontation that so often happens when an individual's told, we're taking you to the ER to be assessed for psychiatric placement. Well, mobile crisis teams can address most any crisis, and we're happy to respond to calls where we can be of assistance when needed. There are some situations where we're not the appropriate ones to address that crisis, and calls should be made to other agencies in those situations. First, we consider individuals where the primary concern is dementia or another situation where adult protective services is going to be the correct call. In those situations, we can assist with facilitation related to adult protective services, but we're an additional step that isn't often needed. Another situation would be a youth, 16 or 17 years old, who's fighting with his or her parents, and there's no evidence of a mental health crisis. Mobile crisis teams can assist with the de-escalation side of this, but in that moment, we're most likely not the correct call. Referrals to CYFD may be in order, or referrals to outpatient counseling might be the best option so that those family issues can be addressed long term. The other side of that are medical emergencies. Sometimes EMS or police will respond on scene. There's an individual who appears to be calm, but will admit to the fact that they've attempted suicide. They're medically stable. They appear psychologically stable. But in these cases, the correct route is going to be transported to the ER. We can come out, we can talk with them, but that's still going to be what happens. An individual who's already shown a propensity for taking their own life is going to be placed. An individual who 15 minutes earlier tried to kill themselves but now is calm, that person still needs inpatient care. They need a higher level than simply making a referral to outpatient counseling. The flip of that is individuals who are acutely intoxicated either on drugs or alcohol. These individuals request that they're transported to the ER, put a PC on hold. Why? Well, for us, it's very difficult given the nature of drugs and alcohol, the way that they impact people's thinking and their reactions to whatever events might occur. It's hard for us to ensure their safety in situations where they appear to be calm, they appear to be rational. 5 minutes later, you don't know that they're not going to act on those thoughts of depression. The opposite is also true. We don't want to say that we need to place an individual based on what they're stating when they're extremely intoxicated, because when they sober up, that may be a completely different situation. The way we look at it is we generally say, if they were driving a car, you pulled them over, if you would arrest them and take them to jail, we ask that you take them to the ER instead. Once there, they'll be medically stabilized, the alcohol and drugs will be detoxed out of their system, and then a valid assessment can be made whether they are safe or they're an imminent risk to themselves. Mobile crisis teams are trained and designed to respond to most mental health crises and resolve the situation to individuals and families. Situations where there's a victim of a crime and they're distraught or highly emotional. Individuals experiencing manic symptoms, depression, anxiety, suicidal thoughts. We've assisted families with processing death of a loved one, either by suicide or natural causes. So many more situations. Think of the mobile crisis team as another tool in your tool belt. One that ensures that those you've encountered are getting the help that they truly need, while ensuring you're able to be available to respond to that next call.